Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh. I am also the medical author of the book Focused Neurology. Today we are going to talk about the localization of peripheral facial nerve palsy. So it's going to be very important from the point of view of MBBS final year students, MD internal medicine students, neurology residents, and perhaps all allied specialties connected with neurology. Very important, basic and interesting topic, the localization of facial nerve palsy. Along with it, I'm going to talk about another fascinating concept, the true tears. Why do we cry when we are sad? The true tears, and of course the all interesting false tears, the crocodile tears. So in this lecture, I'm going to talk about the localization of facial nerve palsy, the true tears and the crocodile tears. Here we go. Facial nerve palsy and its localization. Facial nerve has got four important nuclei. One, the motor, which supplies all the muscles of facial expression. Second, the parasympathetic, which is otherwise known as the superior salivary nucleus, which causes excessive secretion, which causes the secretions to be produced in the lacrimal gland and therefore the tears rolling down from the eyes, the salivary glands and the salivation. So the superior salivary nucleus, the parasympathetic, causes lacrimation and salivation. The third is the taste. The taste fiber, the nucleus tractus solitarius, which carries taste sensations from the anterior two-thirds of the tongue. And finally, we have the sensory somatic afferent, which carries sensations from the ear. Of these four, the first three are important: the motor, parasympathetic and the taste fibers. And therefore, our discussion will revolve around these two nuclei and their fibers, and then the localization. The significance of the sensory somatic afferent from the ear is very small. Right. Now let's talk about the motor and then parasympathetic and then taste. We'll go step by step. At the end, I'll talk about the various manifestations produced at different places of these pathways. Some of the books give the clinical manifestations and localization starting from the brainstem and going to the periphery. But we tend to get confused. If we go from the periphery towards the brainstem, I think it will be easier to remember, because at each level, as we go downstream, we can keep on adding the clinical points. So first, let's see the anatomical concepts and then we'll see the localization aspects. So to begin with, a motor. So seventh nerve nucleus, the motor part, is in the pons. It comes around, winds around the sixth nerve nucleus, and then it comes out. So if there's a lesion in the pons, sixth and seventh nerves can get affected, like Fovile syndrome or Milliard-Gubler syndrome. So once the seventh nerve comes out, it travels along with the eighth cranial nerve. So if there's a lesion here, once it is out of the pons, both seventh and eighth nerves can get affected. So it travels in the internal auditory meatus and comes to the level of genucleate ganglion. Geniculate ganglion contains neurons of taste. So it does not synapse there, it just traverses the geniculate ganglion. And it takes a bend and then comes down, runs in the facial canal. Here it gives a nerve to stapedius muscle. Very important. In the facial canal, the motor nucleus of the facial nerve, as it travels, it gives a motor tweak to the stapedius muscle. Stapedius muscle is for the control of the excessive sound transmission coming into the ear, and therefore if this nerve gets affected, it will result in hyperacusis, that is, the sensitivity to the sounds become enhanced. So it gives a nerve to stapedius muscle, and a lesion there can cause hyperacusis, where there is an increased sensitivity to sudden loud noises. Then it descends down, comes through the stylomastoid foramen and goes through the parotid gland and supplies all the muscles of facial expression. So the important points in the pathway of the motor part of the facial nerve is that in the pons it is close to 6th nerve, so they can get involved together. Outside the pons it is close to the 8th nerve, they can get involved together. And then as it comes down the geniculate ganglion, it gives a nerve to the stapedius muscle. If it gets involved, it results in hyperacusis, increased sensitivity to loud and sudden noises, comes to the stylomastoid foramen and supplies the muscles of facial expression. So if there's a lesion there in the stylomastoid foramen, only the motor fibers get affected. Right, this is about the motor part. Now let's see the parasympathetic part, the superior salivatory nucleus. So here it's drawn in blue color. The superior salivatory nucleus, the parasympathetic, comes from the pons. It travels in the 7th nerve. At the level of the geniculate ganglion, it does not turn and go down, it goes straight ahead. Here it separates from the parasympathetic fibers which are destined for the salivary glands. So parasympathetic fibers up to the geniculate ganglion, both the parasympathetic fibers supplying the lacrimal gland as well as the parasympathetic fibers supplying the salivary glands run together. But at the level of the geniculate ganglion, they separate out. The fibers destined for lacrimation, they go straight, whereas the fibers destined for salivation, they descend along with the facial nerve. Very important point, because if there's a lesion below the geniculate ganglion, only the nerve fibers meant for salivation get affected, whereas the nerve fibers destined for lacrimation, they get spared because they don't come down from the geniculate ganglion, they go straight ahead. So it goes straight ahead as greater superficial petrocell nerve. It goes to the pterygopalatine ganglion. From there, it gives fibers to the nasal and the palatal glands, as well as the lacrimal gland for lacrimation, along with the second division of the 5th nerve. So the important point is that till the geniculate ganglion, the parasympathetic fibers for lacrimation and for salivation, they are together, but once out of the geniculate ganglion, lacrimation fibers and the fibers destined for salivation separate out. So this is the pathway for the lacrimation. The pathway for salivation is that it comes along with the motor nerve, and then before the stylomastoid foramen, that is in the facial canal, it goes as the chorda tympani. It goes as the chorda tympani, and along with the third division of the fifth nerve, it supplies the submandibular ganglion, which supplies both sublingual and submandibular glands. So the parasympathetic fibers come from the superior salivatory nucleus in the pons. They run together up to the level of the geniculate ganglion. Beyond the geniculate ganglion, lacrimal fibers meant for lacrimation go straight ahead, whereas fibers meant for salivation come down. So they separate out. Right. This is about the parasympathetic. Next comes the taste fibers. The anterior 2/3 of the taste is carried by the taste fibers of the facial nerve, the nucleus of which we call as nucleus tractus solitarius. This is meant for taste. So it comes along with the facial nerve, geniculate ganglion. Beyond it descends down and then travels in the chorda tympani along with the parasympathetic fibers destined for salivation. But just before that, it separates out and goes to the tongue, the anterior 2/3 of the tongue. So the fibers for taste and the parasympathetic fibers for salivation almost run together just before they separate out at the end. So this is an overview of the facial nerve, its subdivisions and the pathways. Now let's see the clinical manifestations at each level. As I said in my beginning of the class, most of the textbooks start from the brainstem and then descend down. It creates confusion. We'll start from the bottom at the stylomastoid foramen, and then we'll start ascending up to the pons and see what are all the clinical manifestations, because in this method we can add each clinical presentation as we ascend up. So at the level of the stylomastoid foramen, only the fibers meant for the muscles of facial expression are affected. So at the level of the stylomastoid foramen, only the fibers meant for muscles of facial expression are affected. So they have the muscles of facial expression being affected. Others are all present. The taste is present, the salivary, the lacrimation is present, salivation is present. So at the level of the stylomastoid foramen, only the paralysis of muscles of facial expression is present, but the taste is intact. When you come at the next level, that is below the geniculate ganglion and below to the nerve to the stapedius muscle, we have, in addition of the muscles of facial expression being affected, the taste also gets affected. So here, in addition, the taste also gets affected. The taste also gets affected along with the muscles of facial expression. Below the geniculate ganglion, but above the nerve to the stapedius, so now the nerve to the stapedius is also affected. So in addition to the muscles of facial expression being paralyzed, in addition to the taste being affected, in addition to the salivation being affected, they also have now hyperacusis, sensitivity to loud noises. Now, if there's a lesion above the geniculate ganglion, in addition to all these manifestations, the lacrimation also gets affected. As I said, at the level of the geniculate ganglion, lacrimation and the salivation fibers separate out. So above the geniculate ganglion, both get affected. And if it goes slightly proximally, the 8th nerve also can get affected, resulting in deafness. And if we go still more proximally in the brainstem pons, the 6th nerve also can get affected. So when we go from the bottom and then start ascending up, we can add each clinical feature which gets affected as the lesion goes upstream, progressively up. So we can broadly divide as three areas where there could be clinical manifestations: one the stylomastoid foramen, one below the geniculate ganglion, one above the geniculate ganglion. At the level of the stylomastoid foramen, only the muscles of facial expression are lost. Below the geniculate ganglion, the salivation is also lost, the taste is also lost, and if nerve to stapedius gets affected, there will be hyperacusis, but lacrimation is intact. And the lesion proximal to the geniculate ganglion, along with the muscles of facial expression being affected, along with the taste being affected, along with salivation being affected, along with hyperacusis being affected, the one additional finding which is also lost is lacrimation above the geniculate ganglion. We still go proximally, eighth nerve gets affected. If we still go proximally to the pons, even the sixth nerve can get affected, that is in the pons. So if we go systematically, we can clinch the diagnosis. We can say with the clinical manifestations where the lesion is. This is one part. The other fascinating part is the lacrimation coming from the lacrimal glands and tears. So lacrimation and tears. Why do we cry? What is these true tears? And what are all these false tears known as crocodile tears? So tears is crying or lacrimation when we are sad. So the tears coming down from the eyes as excessive lacrimation is known as true tears. The tears start coming out from the eyes when the production of lacrimation is more than the drainage of the lacrimation coming through the nose. So the production of these secretions are more than the drainage of the secretions through the nose. The tears start coming out from the eyes. The true tears could be of three types. One, the basal tears. Second is the reflex tears, and third is the emotional tears. So true tears could be of three types. One is the basal tears, second is the reflex tears, and third is the emotional tears. The basal tears occur in basal conditions. Normally it occurs. It is to lubricate the eye and protect the eye. The reflex tears occurs when there are irritants. So it tries to wash away, fizzle out all these irritants. The classic example is onions. When someone cuts onions in the nearby area, we have tears coming down from the eyes. It is because of the irritants produced by the onions which the eyes are trying to get rid of. So reflex tears are produced when there are irritants, and the true tears when we are emotionally upset and sad. These two emotions, crying and laughing, are seen only in human beings. They are not seen in animals or other mammals. So this emotional phenomenon, crying and laughing, differentiates human being from other animals. So when we are sad, we start crying. When we start crying, when we are sad, the limbic system gets activated. The limbic system is the emotional part of the brain. It gets activated. It sends impulses to the hypothalamus. Hypothalamus is the chief organ for both the autonomic nervous system, and it connects the emotional part. So when the hypothalamus gets activated, there is a reciprocal innervation going on between the endocrine system, the autonomic nervous system, the parasympathetic, sympathetic, and the emotional system. So when we are sad and depressed, the body wants us to relax by upregulating the parasympathetic system. We all know that the parasympathetic system is meant for rest, digest and relaxation. Sympathetic system is for fight or flight. So when we are sad, the parasympathy and the impulses are conveyed to the hypothalamus. It tries to upregulate the parasympathetic system and tries us to relax and cool down. So one of the main features of the parasympathetic system overactivity is lacrimation. Parasympathetic. So we start crying. So we start crying when we get emotionally upset, sad, hypothalamus, parasympathetic, trying to relax the body. Hypothalamus is the center for autonomic nervous system activity and emotional system. In fact, hypothalamus is connected not only with the tears and crying, it is connected with laughter also. Whenever there is a lesion in hypothalamus like hypothalamic hamartoma, there is an entity known as gelastic seizures or gelastic epilepsy. They just keep on laughing. They just keep on laughing. So hypothalamus can produce laughing as well as it tries to relax the body by excessive secretion, crying. So hypothalamus plays an important role in tear formation and crying. These are true tears. What is this false tears or crocodile tears? As I said in the discussion that parasympathetic through the superior salivary nucleus, the seventh nerve nucleus, it gives fibers both to the lacrimation, that is tears or the secretions coming from the eye, as well as salivary glands for salivation. So when there is a facial nerve palsy, there could be an aberrant connection between the salivary glands and the lacrimal glands. So this is crocodile tears, an aberrant connection between the salivary glands and the lacrimal glands. So if visceral motor fibers innervate the salivary glands and later they come to innervate the other glands, anomalous tearing occurs. So it's an abnormal connection or aberrant connection between the salivary glands and the lacrimal glands. Whenever we see some tasty dishes or any food which has got good flavors, we start salivating. But these people, because of the aberrant innervation between the salivary glands and the lacrimal glands, when they see tasty food or food with good flavor, not only they salivate, but they also lacrimate. Obviously, no one cries when they are served with good tasty food. So these are not true tears. These are known as false tears, otherwise known as crocodile tears. Why the name crocodile tears? Because the tears of crocodile are not true. It is false. So it is aptly compared with the crocodile tears. They are false tears. So this is an overview of tears, the true tears and the false tears, crocodile tears. The true tears could be either the basal tears, the reflexive tears, or the emotional tears. To understand all these concepts of tears, we need to know the facial nerve innervation with the lacrimal glands and salivary glands. And once we know all these aspects, we can, by clinical examination, we can localize the facial nerve palsy. So the localization of facial nerve palsy becomes very interesting and fascinating if we know all these fundamental concepts. I've enjoyed giving this lecture and I hope you have also enjoyed listening to my lecture as much as I have enjoyed delivering it. If you have any comments, suggestions, please post it on my YouTube channel, and don't forget to like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.